Our next speaker will present femoral acetabular impingement of the hip, Dr. Tom Byrd.
Thank you. I am a consultant for Smith & Nephew Endoscopy and receive research support from them, and also a consultant get stock with A2 Surgical. Let's go back to that title for a second about, I presented my results earlier in this meeting, but I can't really tell you my results are better than yours, much less tell you why. But what I think I can tell you is I think my results exceed my technical abilities, and I think I can tell you why. And that's because arthroscopic management of impingement really isn't a technique, but it's really an overall approach, a comprehensive approach in the management of impingement. And there are various factors that include patient selection, planning, visualization, doing the right operation, and the rehab strategy. As far as patient selection, I think undoubtedly the clearest determinant of successful outcome is going to be picking the right patient. That means pathology amenable to arthroscopic intervention, but also making sure that your patient has reasonable expectations of what you can accomplish with the procedure. As far as planning, if you do impingement, I think you should know about the crossover sign, the alpha angle. You need to watch out for dysplasia. Just an illustrative example, and this is a 26-year-old kayaker. He's got clear evidence of cam impingement. His MRI shows labral pathology and some articular failure, but we got a 3D CT scan, and it showed us a lot more going on the acetabular side, where he's got a separate bone fragment, a more substantial pincer lesion than we would have suspected from the plain x-rays. Another illustrative example, and this is a Marine who's got an obvious separate fragment off the lateral acetabulum. MRI partly reflects this, but on his CT scan, he's got a complex lesion with an os acetabulum anteriorly, pincer impingement, cam impingement, as well as a separate posterolateral bone fragment from the acetabulum. Visualization is critical. I tell people that next to poor patient selection, poor visualization is the root of all evil in hip arthroscopy. If you can't see well, you're simply not going to do a good job, or it's going to take you too long to get it done. Proper portal placement is essential for optimal visualization and access. We'll use 3 routine standard portals for arthroscopy. We'll use supplementary distal portals for labral repair. I don't use the distal portal as a substitute for my standard portals because it compromises your access to the joint. Here we're burring the acetabulum from the anterior portal, and there's a variety of instrumentation systems available now where you can even place your anchor systems percutaneously. You don't even have to make a separate portal. The purpose of having it more distal is so that when you drill the acetabulum and place your anchors, you make sure that you're diverging away from the articular surface, because you do not want to violate the articular surface, which is easier to do in the hip than in the shoulder. Meticulous soft tissue preparation is important, and this is the tedious part of the operation. The preparation and visualization is the time-consuming part, and when you go to do the bony correction, the operation is just about over. You want to make sure you're doing the right operation, because impingement is not a cause of hip pain. Impingement is simply a morphologic condition that predisposes the joint to pathology that then becomes painful, and you can certainly have impingement morphology without necessarily having impingement pathology. We know that with pincer impingement, you primarily get labral damage and secondarily articular failure, and with cam impingement, you get articular failure first and then secondarily labral damage, and the arthroscopic findings are important in your treatment algorithm. With pincer impingement, you look for the labral failure that tells you they're getting in trouble and they have bone overhanging the labrum. With cam impingement, you get the articular delamination that tells you that this is failing from the shear effect of the cam impingement. But you don't have to wait to have a grade 4 lesion. Sometimes there can be a substantial subchondral blister, what's been referred to as a wave sign, an indication of a hip that's in imminent failure because of underlying cam impingement. The rehab strategy is important, and in our experience we found that most times when patients are having problems after surgery, it's because of poorly guided physical therapy, and I'm not casting disparaging remarks on the therapist. That's what our therapists say. Based on our current rate, I can tell you that we have about a 2% reoperation rate, so there's a small chance that they may be getting into trouble and may need something further done, but the vast majority of the time they simply need redirection in their therapy. Just an illustrative example, and this is a 15-year-old level 10 gymnast, symptoms in her left hip for a year. She's got os acetabulum, a pincer lesion, significant cam impingement. She's lost 30 degrees of internal rotation in her left hip. CT scan helps us to quantitate the lesion. We go in arthroscopically, you can see the articular failure, the labrum is failing. It hadn't completely fragmented, but this is a young girl and you don't want to wait until the labrum is destroyed. We're mobilizing the labrum, we'll remove the separate bone fragment. Then we'll recontour the acetabulum, correcting the pincer lesion. We've placed our anchors, placed the sutures. We've refixed and preserved the labrum in this case, and then we'll go to the periphery. And oftentimes this substantial cam lesion is covered in disturbingly healthy looking cartilage, but that's just a protective mechanism by the body to protect the acetabulum from the abnormal bone. We remove the soft tissue, then we'll recontour the recontour the head-neck junction, recreating the normal concave relationship. And you can see a little remnant of her growth plate that grew off asymmetrically, creating the cam lesion. And here we've completed the correction of the cam lesion, we've corrected her pincer lesion and preserved the labrum. This is another illustrative example, a 34-year-old NHL hockey player, been in the league a dozen years. He's got evidence of a labral tear, CT scan suggested cam impingement. Arthroscopically, it turned out just had a big hypertrophic labral tear that we debrided, no articular damage, no arthroscopic findings of cam impingement. So instead of taking 4 months to recover, he's back playing in 3 weeks. So we don't address the x-rays, we address the findings at arthroscopy. Another illustrative example, a female soccer player. She's got an obvious crossover sign, a pincer lesion, a herniation pit. CT scan shows the cam lesion and partly reflects the pincer impingement. We go in arthroscopically and her labrum's pristine. It's got no damage. She has articular failure indicative of cam impingement. But in the presence of a normal labrum, we're not going to violate that labrum to do anything on the acetabular side. So we simply do our chondroplasty of the acetabulum, and then we'll go to the periphery. We've corrected her cam lesion. We've curated out the herniation pit, addressing the underlying etiology. And oh yeah, on the Marine, here's his lesion. We went in arthroscopically. We fixed the posterolateral fragment arthroscopically with percutaneously placed screws, fixing the fragment, getting a couple of screws in there with good compression to stimulate a healing response. We went anteriorly and removed the separate os acetabulum fragment off the anterior acetabulum, corrected the pincer lesion, refixed the labrum. He also had a painful snapping iliopsoas tendon, so we released his iliopsoas tendon to eliminate the snapping. Then we went to the periphery and corrected the cam lesion, addressing all aspects of this military personnel's underlying problem. Here's a finished product where we corrected the anterior acetabulum and fixed the fragment. This is his post-operative x-ray. So just as a brief reflection, what's the future hold for us? Well, I think the future is going to be in computers. I think you're going to find a lot of systems out there. Just like the total joint surgeons use templates preoperatively and use jigs intraoperatively, I think that software planning is going to be the template for calculating what type of impingement correction needs to be done. And I think computer navigation is going to be our intraoperative jig for correctly addressing the underlying impingement. Thank you very much.